Bridges. And before we start with the QA, the question and answers, I do have two questions from the overflow room, and being that they weren't allowed to get in here, I'd like to first have these two questions. So would you please stay seated until I give the okay to, there we go, give the okay to come forward to the mics. This question is asked by John Evermeister from St. Cloud, Minnesota. What will happen to Medicare Advantage plans under proposed legislation? Will these change?
Does my microphone work? Does my microphone work in the Okay, great. Let us know if you can't hear us at any time. Don't be afraid. Don't be shy, and I trust that you won't be. The Medicare Advantage program is something that the President has said repeatedly that he's hoping to see end. And it appears from, again, there's one bill in the House that has been changed in 3 different committees, and all those changes have been reconciled. There's another bill in the Senate that's still kind of in an embryonic stage, so we don't know what the final bill will be. We know the President has said he wants to eliminate Medicare Advantage, and we assume that ultimately Medicare Advantage will be out, although numerous senior citizens across the country appreciate the program. It's actually reduced in a great number of savings, but it appears that's what the President's goal is, and I would assume that's probably what we'll see, and perhaps Dr. Burgess has something he'd like to add.
On the, is this microphone working okay? Dr. Hunter. On the, during the presidential debates last fall, Medicare Advantage was the one thing that was consistently singled out by President Obama as a federal program that he would cut. It's listed in the Congressional Budget Office for $170 billion in savings over the 10-year budget window that they were looking at on this bill. So I don't know, but it does look as if Medicare Advantage will be significantly structurally changed. Now, you do also hear a lot of talk about places like the Mayo Clinic, places like Geisinger Clinic. You hear a lot of talk about developing that type of care model, a so-called accountable care model that would deliver more care for less money. I was at a roundtable in December on just this topic with accountable care organizations, and I was somewhat surprised because 4 of these major multi-specialty clinics in the country that are participating in this study said without Medicare Advantage, it would be very difficult for us to deliver the kind of results that you're asking us to deliver. So the things like care coordination, medical home, disease management, all of those things that we talk about, both sides talk about as measures to save money in the Medicare system, those may be put at risk if we significantly cut Medicare Advantage. So the President also said last fall that he wanted to be careful and do cuts with a scalpel, not a chainsaw. I think this is one where they may want to be careful because there may be more information than they have had than they've had available to them, because they need to talk to some of these groups that are actually doing the kind of work we've asked them to do in these accountable care organizations to deliver more care to more senior citizens at a lower cost. But we'll have to see where that goes.
Okay. The next question comes from the southern part of our congressional district, from Stillwater, Mr. John Baer. He asks, this is directed to Dr. Burgess. As a doctor, have you ever canceled someone who came to you with questions regarding a health care directive? Do you feel that such voluntary counseling should be considered as a death panel?
On the, page 425 through 435 in the bill, the concept was very simple. As a physician, I think it was a good idea. Let's pay the doctor for doing education. Now, unfortunately, that very simple idea has now translated to 10 pages of legislative language. So it's no great surprise that people are concerned about what is contained within there, and the language does tend to be pretty prescriptive. There is also the issue of the comparative effectiveness boards that are not in this bill. They were passed in the stimulus bill last February. So when you marry the language that you find in this bill with comparative effectiveness boards, and you include the increase in the availability of information online, the electronic medical records, which was also part of the stimulus bill, at some point the grand plan is to have a server that's going to have everyone's medical information on that. When you marry those 3 concepts, it does cause people to be nervous, and I understand why people are. To me, the more troublesome language in this bill was the section immediately following the advanced directive section, where it said that physician quality will be measured on the number of people who sign up for advanced directives. It tells me that we're going in a direction that is not the direction that I would recommend we take. I think it's perfectly sane and sensible to have the doctor have a conversation with the patient about advanced directives at the time of initiation of Medicare. Welcome to Medicare Physical seemed like an appropriate place to do that. I thought we ought to pay the doctor for that, because some people in Congress were so worried that doctors would game the system and submit that charge every time they saw a Medicare patient. They said, we're only going to pay for it every 5 years. That's where the 5-year interval came in, and then the other language in the bill, unfortunately, rather than being comforting, was discomforting to more and more people who read it. And again, that's one of the reasons why it was a good thing to have the bill out for people to scrutinize and look at.
If I could just add to that, I think promising to cut costs by having a panel of Washington bureaucrats make the decision about what type of medical treatment people are going to have hasn't proved to be a real popular idea across the United States. And I think that's where a lot of this has come in. Again, it goes back to the central crux. Who's going to make the decision over your medical care? Will it be you, or will it be a nameless, faceless bureaucrat? And I just want to direct your attention to the board that's up here on the stage. We may have copies of this for you to take. The bill that's in the House, H.R. 3200, creates 53 new bureaucracies. It's a full employment act for bureaucrats. And so just consider, put yourself, your children, your elderly parents on one side of that board, put your doctor on the other side of the board, and just recognize you have to go through these 53 new bureaucracies to connect yourself with your doctor. That's why you see people all across the country saying, I'm not real comfortable with this. And I think that's why people have the right to ask questions. You ask questions now before the bill is passed, not later, afterwards, because Washington is doing a lot right now saying, trust me. Just trust me. The American people are saying, we don't trust you.
Okay, I just want to remind everybody that when I give you the direction to go ahead and line up, that you keep your, state your name and where you're from, what city you represent, and keep the issue to health care. And just just another reminder, you know, I wrestled and coached for a total of 45 years, so be careful. We'll keep this so that everybody gets a chance. And by the way, I'm going to extend it to 4:15. 4:15. And the young lady to my left, your right, was I think at the microphone first. So we'll start on the left and we'll go to the right. So, okay.
Thank you. I'm Christine Norton from Cottage Grove. Congresswoman Bachmann, I share your concern about the costs of medical care. I'd like to know how you feel about evidence-based medicine, and you've already somewhat said about comparative effectiveness research. My understanding of those boards and looking at the composition of them is that it would not all be bureaucrats. There would be medical people on there. There actually is consumer representation, which is another concern of mine, to have consumer representation on any boards, panels, or commissions that are developed through this legislation. I believe that evidence-based medicine, shared decision-making, and comparative effectiveness research will help us to control over-treatment and some of the high costs of medical care. Thank you.
That's a great question. That's a great question that you're asking. And I would agree with you that I believe that we will see medical people, consumer representatives that are on the board, and evidence-based medicine is not a bad thing to look at, because we want to make sure that we are incorporating best practices. But I have to go back to my initial premise. Who's making that decision? If you have more competition with